Thank you, everybody, to be here, especially after eating. I hope I will try to give good numbers for Monday. I would like to give you a different point of view of what is the third dimension in the biologic width. Anybody knows that biologic width is very important, but anybody do not want to know what is biologic width. And most of the time, people hate biologic width because it's the question the students never want to be questioned during the examinations. It's something strange. But actually, it's really, really simple. I would like to describe this in two studies and give some news because I don't want to say what was already said in the literature. As soon as we treat a case in a static area, we would like to be more aware on how and when and in which way this tissue will mature during time. In order to define the tissue maturation, I would like to describe in this very, very little timing I have how the tissue thickness is correlated to the tissue maturation over time in the zenith area, so in the most aesthetic part of our smile, and how the emergence profile has an interaction with the tissue maturation pattern. So let's go deep into detail and have a look at the background of what the biologic width is. So very easy saying, biologic width is just the distance between the free gingival margin to the first bone-to-implant contact. It's just a measurement. But what does this measure? The thickness of epithelium and connective tissue that protects the bone. So these two actors want to give a mechanical, bacterial, and chemical protection to bone. When they fail, they change dimension, they change position, they reposition. When they succeed, giving a stable balance, they stabilize, and over time, we will not have recession. Our aesthetic will be kept exactly as we left. So, going into detail, our problem is that we have no data on the horizontal dimension of the biologic width. This is a word which is three-dimensional. It's not only one-dimensional. So we need a second dimension in order to better understand what happens to tissue. Otherwise, we are blind. We cannot understand the three-dimensional things of any being with only one eye. So let's go deep into detail for mentioning the connection, interaction with the biologic width. Anybody knows connection is really important. And I really have to thank Dr. Park because he entirely inspired this presentation and all the data that I will show today. So he presented me in a presentation the study from Wenstrom that were establishing an equilibrium that usually occurs on natural teeth. So the ratio between the height of the tissue and the thickness is quite constant between all the teeth who are healthy. This is a relationship which is 1.5 to 1. It's a proportion. But this proportion totally changes on implants because there is a remodeling. Where is it? Here. There is a remodeling of the tissue. They drop down, and we lose a little bit of aesthetic. And this was well described by Nozawa. So you can notice that there's a drop of tissue while we pass from teeth to implant, and we don't want to risk this. The pumping effect has a terrific action in this mechanism. Zipprich described it very well, and he explained, I think, the word entire better than most of the authors that together with him made the studies, that connection may be very harmful for bone and tissue. Imagine having this just next to the bone. There is something called pumping effect. So bacteria, endotoxins, and many other things that stays in incubation inside the implant are just pushed out the implant through the connection during the masticatory cycles. And they give a local infection, and at the end, it ends up with an apical repositioning of the bone. But his slides end up here. I want to see what happened next. So in order to understand what happens next, we know that Zipprich gave the answer why Albrechtsen told us that after using implants, in the first year it was normal to lose 1.5 millimeter of bone surrounding the implant. But actually, we want to do something more, because we know a lot of things about bone, but what people matter when they look themselves at the mirror is what happens to tissues. So what is the relationship between the connection and the tissues? So going back to Nozawa, he stated that there was an apical repositioning of the gingival margin in this model. But is it possible that if we change the connection, this is, for example, an any-ridge 5 degrees connection, which is very efficient giving a sealing. Is it possible that this stabilizes the tissue better than the other connection? Is there a direct, measurable relationship between the two things? So I present the study one. It's a pilot study where we measured the thickness and the height of the tissue around the implants through a direct measure on models after impression at the zenith level, the buccal zenith level. What you can see is that the relationship between the height and the width of the tissue in the zenith area totally changes. It becomes 1-to-1. So we increase the height that can be stabilized around this kind of implant. So the ratio is very, very next to 1-to-1. This was done on 32 implants. But of course, we need a statistical significance, which is here. But we need some more numbers in order to better define what's happening and increase our knowledge from a 3D point of view. The study number 2 is a little bit more complex and derives from study number 1 because it was the pilot study for this one. And we've been measuring the tissue maturation over 2 years later on 294 implants. This was a huge work, and I really have to thank my whole team. It's called RollFlap, and they helped me doing such a work. It took 2 years for 2 people to measure all the samples they had. So it's really a terrific work that they did for 2 years, measuring everything. And we tried to analyze three-dimensionally what's going to happen to the tissue maturation up to over 2 years after the provisional placement. So you can see how the measurements were done. It's very precise. If you do that digitally, you're precise up to 10 microns. So nothing escapes from our analysis. We go directly into the detail. So we made a comparison, a direct comparison between 5 degrees connection and a flat-to-flat connection. We were very lucky because the thickness, you see the blue lines here, in both the samples were exactly the same. The average was exactly the same. So it's perfectly comparable as a sample. So with 5 degrees Morse cone connection, again, we go very next to 1-to-1. So we confirm the data that we had in the pilot study. But if we pass from a 5 connection, very efficient Morse cone connection, to a flat-to-flat, you see that it goes back to 1-to-5. So it means that the tissue remodels vertically, losing height. And this, for our patient, means that while smiling, the tooth is longer. They have a recession. And there's no way to avoid this. And the significance is really high. 0.014, it's a lot. And of course, this is why ZipRich gave us those data. So let's add one slide to the ZipRich, because now we have a sliding door situation. If you have a flat-to-flat connection, what will occur after is a repositioning of the tissue. I created this slide with Photoshop, using his one from his article. So you have an apical repositioning of the free gingival margin. But if you have a 5 degrees connection, we showed from our numbers that that was not happening. Tissue was staying stable. Because what is in the middle, the inflammation and the pumping effect, probably was inside the window of tolerance of our patients. So without giving a negative reaction to the volume of tissue. This is one of the many variables that actually we need in order to try to be able to predict where tissue will go after our implantation. So when we substitute a tooth with an implant, we should know how the nature works. We need to know the numbers that describes what actually happens to those tissue in order to be able to, let's say, try to predict as much as possible, as more precise as possible at 4 years how tissue will be. This is a very complex graph, so I will ask you 1 minute of attention. It's a little bit complex, but it says amazing things. I'll try to explain. This is the width, and this is the height. This is the graph with this description. In the dots that you see in the middle, so these little lines inside, they describe the gingival height over the years. So the final prosthodontics was delivered, and the height of the tooth was measured at that time, after 1 year and after 2 years. So we can define from this graphic that we will have a recession if the height of the tooth increases. And we will have a creeping, so we will have tissue that addicts, that just crowd on top of the tooth when those little lines go up. So looking at the graph, you can see that there is a tendency. The tendency is, if in all those implants we had, at the delivery of the final prosthodontics, less than 4 millimeters of thickness of tissue at the zenith level, we were always experimenting recession. And this is highly significant at statistic level. But anytime we had more than 4 millimeters of thickness, we were experimenting creeping. Tissue were going on top of the implant, on top of the crown. So the predictability of the aesthetic in the area we love more, which is the frontal area, was more predictable, was more achievable. So I suggest heartily at the delivery of the prosthodontics to measure the tissue thickness. If you have less than 4, be careful. Probably you will have a recession soon. It will take a couple of years. Does emergence profile has a role in this? It's very tough. I have 2 minutes left, and I will try to merge all these concepts together. So I will skip all the other designs, but I love somebody whose name is Nitzan Bichachu. And he loves saying that he creates crowns with the tulip line. He's romantic. But the tulip line is fat, is big, even at the bottom. What Dr. Park likes, because he inserted this in any component of the Megagen line, is the S line, which is completely different. It's a concavity and then a convexity. So if we compare the two different emergence profiles that in that group were analyzed, you can clearly see that after 2 years, if you have a design like this, the tissue, the buccal tissue, again, will show an average 1 millimeter of recession. So the S line is extremely precious in order to stabilize tissue over time. So as a take-home message, I would like to enhance the rule of connection. The connection must be a perfect one, but not only a conical connection. A conical connection who's made by a company that controls piece by piece, that is well done, that there are no errors. And please do not emerge too wide in the deep part. Emerge with a nice S line. What does this mean? It means that you have to be very narrow and skinny in the deep area of the biologic width, because you need the width of the tissue. The more ceramic you place, the less tissue you have. The less tissue you have, and the less connective ring you have. What means less blood supply for the tissue, especially in the zenith level, where we do not want recessions. And be wide on the top of the free gingival margin, because you need something that helps protecting, from a mechanical point of view, the tissue. So use the S-line as your philosophy of work every day, and you will see that tissue will be more happy. And remember, 4 mm is our threshold in order to have a good prognostic avoidance of remodeling of the free gingival margin and recessions. So please try to achieve as much as possible a good S-line. Even if you do immediate loading, secondary loading, whatever you do, even if it's Toronto, you do S-line. So be very skinny and little in the deep area and rise very wide and protect tissue under that. And of course, teach patients on how to clean their implants. I thank you so much, and thank you very much, Scott, again, for the kind presentation.